Welcome, everybody. We can all sit down. We haven't got a fireside, but we're going to have a fireside chat anyway. So I'm really honoured to chair this open plenary with such a fantastic panel of really informed and interesting speakers. So immediately to my left, we have Bettina Ryll, who is the founder of the European Melanoma Patients Network. Next to Bettina, we have Ken Milne, who is a community emergency physician and also the creator of the Skeptics Guide to Emergency Medicine. We have Dianne Carmichael, who was described as a serial innovator earlier today, and she's also the chief advisor to the Canadian Council on Innovation. And finally, at the end there, we have Tom Maston, who is the Deputy Minister for Health in the province of New Brunswick. And we're going to open up with just some gentle opening questions so people on the panel can explain the way they think about value and the nature of the policy problems we've got ahead of us. And then we'll open out to the floor. Hopefully, if you look on your tables, you'll see that there's these nice questions. If you have a question for the whole panel or individual members of the panel, if you just complete one of these forms, there's runners around the room, and they will bring them up to me, and I will relay your question. So I think it's always good to start with the patients. The patients are what it's all about. It's what the healthcare system is appropriately focused on. And so, Bettina, if you don't mind going first, when we're thinking about value and we're thinking about the patient's role in determining value, what would you say is the patient's responsibilities to think about value in how they interact with and use a healthcare system?
Well, okay, that's of course directly starting with a tricky question, right? So I would actually challenge the frame of the question, because it's a bit like, shall we eat soup with a knife or a fork? Is it really a patient's job, if you want, to think about everyone else? You're dealt with a diagnosis that can be disastrous. So for my personal experience, my husband was diagnosed as stage 4 melanoma patient from one day to the next, and we went from planning a third child to preparing for his death. Is that a situation where you want to start worrying about everyone else? Or is this rather today a symptom of a system failure, where if we think about healthcare system, at least of what I call developed healthcare systems, where we have the ambition to provide health and care to everyone on a fair play, is it really happening? Or are we now trying to push the responsibility from that system towards the patient, who in the end is the weakest link, if you want to think about it? And I actually see that as a deep problem of our current situation. It's not that I have a solution, unfortunately, because I'm sure that would have been the next question coming. I would rather think that it is a role as a patient advocate to point out where there are the issues for our patients, because we are eventually all going to be patients. People like to say, oh, we are all patients, and I obviously disagree with that, because having a flu is not the same as having a life-threatening disease. So I distinguish between patients and undiagnosed patients. I think the problem with this entire value discussion that we're currently having is that we are putting a person who is in extreme distress in a situation where they have to make trade-offs. And lots of these trade-offs are actually sneaky, nasty restrictions of what I consider as rights of a person. If you think of our societies, health is part of what we consider as citizens' rights. It's not considered a perk that comes with your job or something that you just pay for because you've inherited lots of money. It is something that we consider a part of who we are in the societies we live in. So if you then go to a patient and say, well, is that really worth it? Is your life worth that much? It basically questions that right. And the right to live is actually a human right. So it's not just a citizen's right, it's a human right. So we're going into a very dangerous territory. And I think this is a discussion we should be having much, much more. It's not just about resources allocating to value, but what type of society do we want to live in? What are our values as society? And how do we make our resources go further? And I mean, Brian already alluded to it. We're in changing times, and I think we have to have a much broader discussion than just on value. It's about what type of society do we want to live in, and how do we actually make this possible? Because in the end, our resources are limited.
Thank you. That was excellent. So if that doesn't give people out on the floor some material to generate questions, then I think people weren't listening. That was fantastically powerful. Ken, if I can come to you now. So you're obviously very strong in the evidence-based medicine world. You do a lot of work to push the support to clinicians in practice, especially in emergency medicine, to give them access to good evidence-based medicine. How does evidence-based medicine help with this value discussion? Can we leave it to the evidence-based medicine community to solve this value discussion for us?
I'm going to sit forward here. You know, it's supposed to be a fireside chat, and so I feel like I should start by saying, hi, my name is Ken, and I love evidence-based medicine, because I'm a bit of an EBM nerd, but I want to make sure that you understand what I'm talking about when I say evidence-based medicine, because EBM means different things to different people, right? And most of the time when I say evidence-based medicine, it might mean something different to the government, to the innovator, to the patient advocate, or to the physician. And most of the time when I talk about EBM, people think, oh, it's about the literature. And you know what? It's not. So I want to bring people back before we start. I want to bring people back to the early 1990s. So this is a bit of a like time zone thing. Doodle-doo, doodle-doo, doodle-doo. Okay, 20 years ago, okay, Dave Sackett said, evidence-based medicine is the conscientious, explicit, and judicious. Those are big words. Conscientious, explicit, and judicious use, not of just any evidence, but patients want the best evidence. And physicians do it. I don't see populations. I treat one patient, one at a time. And so I want to make individual choices based on the best evidence. And the only thing I'd add to that definition, it should be shared decisions, because most of the stuff we do in medicine, there is a lot of answers, not just one right answer. There's lots of right answers, but the patient needs to be involved. And so when you think evidence-based medicine and how we're going to do it and how I do it at the bedside, is I think of it as a Venn diagram, and you've got the patient and their values, expectations, and desires, my knowledge, skills, and attitude towards that, and my abilities, and then the literature. And it's the literature that guides me and directs me, and that evidence helps me provide value to that patient. But that patient isn't going to remember a p-value of 0.001, and they won't remember a confidence interval ranging from this to this. What they're going to remember is how I made them feel. And so I use the evidence to guide my decisions, to make shared decisions for individual patient choices so they get value out of the research that's being done. And there's a problem, because it can take 17 years for high-quality, clinically relevant information to reach the patient's bedside. I've been practicing for 20 years now, so right now I'm about 3 years into my training. Because I was taught, right? 17 years for that information, that really good stuff, to reach the patient. 17, and it's not for 100%, it's for 14% of that high-quality, clinically relevant information to reach the patient's bedside in 17 years. And we can do better than that. Thank you.
Thank you. So we clearly need to innovate. And that brings us very neatly and naturally.
She's going to do better. She's
yeah.
Better. I already know she's better. I met her last night. She's way better.
So Dianne, how do we do better? How is the innovator community in Canada going to help us to do better, to think about value, and to help the health systems deliver more value?
Well, we're going to bring, we'll bring some technology to help you with, shrinking the 17 years. So I think I've got some of the people around to help us with that. Anyway, thank you very much for having me. I thought that perhaps not everyone here is familiar with CCI and what I represent here. So first of all, perhaps I could just give a brief overview of CCI. CCI is a business council for the 21st century economy. It's chaired by former co-CEO of BlackBerry, Jim Balsillie, and vice chaired by John Ruffalo, who's the CEO of Omers Ventures, with a mandate to directly connect Canadian technology CEOs with senior public policy leaders in order to drive the growth of Canada's innovation-based economy sector. Our members are CEOs from coast to coast to coast of Canada's most successful and fastest growing technology companies. So we represent about 70 of those firms and about 20 of them that are focused in health technology and growing. We know that Canada's innovation economy is created, regulated, and managed by governments and its agencies, and that their decisions have direct and profound impact on the innovation sector and the innovative companies in Canada. So we want to be at the table. CCI is dedicated to helping indigenous high-growth technology companies scale up globally. So we advocate for public policy focused in 3 areas, and that is access to talent, access to capital, and access to customers. I'd like to point out that CCI, in its short 14-month history, has had some tremendous success in partnering because of some forward-thinking and collaborative policy makers. So together with Health Canada, with the Government of Ontario, Ontario's Chief Health Innovation Officer, Bill Chernitsky, and of course, Dr. Brian O'Rourke and his team at CADTH, we've created and established 2 working groups that focus on data and digital health, and also on medical technology devices. So we're encouraged by that dialogue, the sharing of ideas, and very grateful for the efforts. So as we sit here today, we're discussing healthcare and value. You may wonder, sort of why and how the innovation economy is critical to the discussion. In Canada, we know our single-payer healthcare system has long been a source of pride and national identity for Canadians, and in fact, I like to say that we're often defined by 3 things: our taste for beer, our hockey prowess, and our un-American universal healthcare system. However, sadly, healthcare costs to government, to individuals, to employers, projected to grow well beyond sustainable levels due to demographic shifts and economic challenges. So health spending consumes, as we know, nearly half of provincial budgets. In Canada, or in Ontario alone, that's rising to about $52 billion and tends to be holding at that level really only because of artificial and often damaging limits to spending growth, often through rationing access and care for patients, rather than true system transformation that could help us by adopting some of the homegrown Canadian health tech innovation in this country. So our 19th century acute care worldview did not conceive of our 21st century technological reality. So we have to try to build value, or we are trying to build value in an outdated delivery system that was designed around episodic care, hospitals, and providers, rather than patient-centered and value-based care that focuses on health and prevention and incorporates Canadian technology innovation to improve our often suboptimal performance and outcomes. So we have to find ways to get better value for our healthcare dollars, and in business terms, because that's where I come from, that's measurable ROI. As a country, we can't remain globally competitive with a healthcare system that is a drag on government budgets, nor can we derive both improved patient outcomes, which should be our overarching goal, and economic benefit with a system that doesn't adopt innovation, doesn't maintain and protect the IP created by those investments, or the inventions that are being developed by Canadian health tech entrepreneurs, who are, by the way, personally invested and passionate about making a difference to sustain our universal healthcare system. Most of whom, ironically, We force to sell their products and services outside of our borders without ever gaining traction here in Canada. And then we proceed to license back the IP and products that are snapped up at a discount by US and global multinationals. So we can't continue, as we are today, to be net importers of health technology. We have some of the biggest and brightest right here. So we need to focus on growing Canadian health technology companies, buying and building and buying Canadian, if you will. A little anti-Trump. We must truly embrace the reality that healthcare is also an economic driver, not simply a cost center. Health's a growing sector worldwide. All countries are facing the same issues about sustainability, trying to understand value in an effort to maintain sustainability. Both demand for health services and innovation are multiplying at dizzying rates. Technology, including artificial intelligence, is advancing at exponential rates, but it has exponential potential to completely transform and impact when it's applied to health and the healthcare system. And Canadians are global leaders in many of these areas in technology. In fact, machine learning that was essentially invented here. We have to devise policies, focus assessments on these new technologies, be agile in that, deal with the inherent risk in our system that prevents the adoption of innovation, and really bring the voice of scaling health tech CEOs to the table with policymakers and regulators in order to truly transform the system, make it an economic driver, and deliver the true value that Canadians deserve. So that value, in my opinion, should neither be a veiled code word for cost reduction, and it shouldn't be just a theoretical ideal. It really is health outcomes for patients, or health consumers, I like to say, that is value, and we must have real-world return on investment. So by helping the innovators with access to capital, talent, and customers, and truly adopting innovation, we can realize that ROI and create sustainability that allows us to maintain, our national dream of healthcare for all. I think we truly do sit at a crossroads in Canada of an incredible opportunity, not only to deliver the best patient outcomes in the world and true value, but also to create economic impact for Canada as a whole. So it's time we included Canada's leading health tech CEOs to the table to help create that future and begin to adopt their innovation, truly adopt their innovation, and protect the IP for the betterment of all Canadians for generations to come. Thanks for listening.
Thank you very much. Another presentation where we, if there weren't words that either made you cheer or want to scream somewhere in Dianne's presentation there, I think, again, you must have been not listening the way I was listening. It was fantastic coverage of the landscape and real meat to the discussion we're going to have today. So, Tom, you've heard a lot of mentions of patients and a lot of mentions of value and a momentary acknowledgement of population. So we're passing through Ken, and evidence about populations. How are we doing at getting that balance between looking after the whole population and looking after the individual patients currently, do you think?
Yeah, I guess, as we've mentioned, being in Canada, we have universal access. The vast majority of the funding for that does come from ministries of health. And as the Deputy Minister of Health, I often find myself sitting in front of Cabinet making recommendations on where that funding goes. In any given year, every province in the country, every government has a fixed amount of money typically that they're dealing with, and so they will turn, when it comes to healthcare, they will turn to their healthcare ministry and say, okay, what can you do with X amount of money? And you try to bring a value framework to that, and governments want the same thing. And the example I'll give is a very simplistic example, but I think it underscores the challenge of trying to bring values to very difficult decisions. On the one side of the value chain, you can have, I guess, what's called the public health, and I mean small p, small h, the public health status approach to funding. So, for example, in a province the size of New Brunswick, 750,000 people, If we are down to our last $1 million that we can allocate somehow, and we're the province that has, I think, has the fewest publicly funded vaccination programs in the country. Putting $1 million into the vaccination program may benefit literally thousands of New Brunswickers. On the flip side of that, we are also in a healthcare system when someone is being treated through the hospital system or the acute care system, where, as has been mentioned, you know, the focus is the care provider with the patient and doing everything you can for that patient. And that's also a very valid perspective. But we now have situations with treatments, whether they be pharmaceutical treatments or otherwise, that can easily cost $1 million for that one individual. And so if you're in the situation of down to your last $1 million, and on the one hand you can make a decision that maybe impacts the health status of several thousand people, or that $1 million can be directed towards one individual where maybe you save their life, that becomes a very real value discussion. And I haven't found the framework yet that helps us with that. But I can tell you from personal experience, I have sat in the minister's office with a minister of health of the day having those discussions. And it is a very lonely place to be. And I think as a society, we're going to have to start to have those talks. So when I hear value, that's the struggle that I face.
Thank you. I think you ended on a really important note, and it's a note that Bettina started with, which is, as a society, we have to have these discussions on value, and that's a really challenging place to be. And so we have one question already from the floor, and I didn't write this at all. As a health economist, it's kind of one of the questions I'd ask, but I'm not responsible for this. And it's to the whole panel, and it's saying, okay, how do we make sensible or have sensible discussions and make sensible decisions about value when our biggest neighbor and trading partner has a system, for want of a better word, that has no limits on public payment for new technologies, and an explicit legal exclusion of the consideration of issues such as cost effectiveness and indeed cost for drugs for Medicare and Medicaid in deciding what they pay for. I mean, that's a terribly difficult challenge because it's such a different social value set. How can we move forward with that on our doorstep? Anyone want to have a go at that?
Let's make healthcare great again.
Macca.
That's all I got. Yeah, no, but it's a society question, and I don't think we should always be judging ourselves based juxtaposition to our big neighbor. I think we should make decisions about healthcare based on our own values, and whether that's the 3 H's: healthcare, hockey, and Hortons. But I think that you got that? Did you? Good. Okay, so we should be basing it on the evidence. Right? And if we don't have the best evidence, and we need people in the audience and the students out there to create that evidence and to find out that evidence, so then people like you're creating innovation, but people like you can then decide in that minister's office, $1 million, what do I spend it on? Well, you need really good evidence to say this drug does this or these vaccines work for that. And if you don't have that, then we're not getting value. We're not getting value, at least the best value we could. So we really need to go back to what's the evidence show and then interpret it.
Thank you. Bettina.
So, well, I'm European, in case you haven't noted, and this is obviously a question that we are asking ourselves, because it is not only Canada that is affected by the direct neighbor, but it also affects Europeans directly, what happens in the US. So first I would argue that even the US is changing their approach. There are HTA processes already ongoing in the US in a different style than we're usually doing them, but they are already happening. So I think there is a way to align, and also the inability to negotiate for price, I think, is something that is not as set in stone as it used to be. So there's, from my perspective, there's hope for that. At the same time, our countries are relatively small. Well, I mean, population-wise. I wouldn't suggest that Canada was anything like small. But if you look at Europe, our countries are tiny, and we're somehow not able to get our acts together and act in unity, because if you actually counted us all together, we would have the populations that would be of interest for any market size. So I'm not so willing to just go like, oh yeah, we are too small, we are too irrelevant, if we even haven't tried to sort out our act. So I wouldn't be as negative. I think we have to change approach.
Just because you have the technology, though, doesn't mean it's better. Right? And we worship technology. And I'm not saying technology is bad. I'm not saying technology is good. But we should. Sorry, I'll move this way. But you know, it's how you use the tool, right? That's really, really important. So just because every 7-Eleven in the United States, and I've not been sent by 7-Eleven, every 7-Eleven in the United States has a CT scanner or an MRI machine or a PET scanner, doesn't mean they're getting better care. It just means they're getting more care. So it's how we take those innovations, and we're good about this, right, in Canada. We take these innovations and then use them appropriately and put them where they're needed so we do get the value. And it's not just a matter of, oh, we can scan it. Oh, you've got a head? Let's get a CT scan of that. You know, like it has to be, you have to think about why am I doing that and what's the harm? Because implementing any technology, there's an upside, but there's also a downside. And finding that balance, and that balance, I would suggest, is the value that the government's looking for.
The comparison to the US is always interesting. And I mean, I'll talk about numbers for a second. I am an accountant by training, so the dollars enter into it for me at some point. But you know, when you look at the US and their expenditure per healthcare, expenditure for healthcare per capita versus us, they're about 50% higher in what they spend per capita. But we also know in the US, about a quarter of the population there has a really difficult time finding basic health care. So that tells you that there's a large cohort in the US that has significant financial resources for health care, way beyond what the average Canadian or a lot of Americans have. And it truly is, in a lot of cases, there are people in the US who are getting the best health care in the world for the issue that they have. And that's a society that's built on the rights of the individual, and you hear this debate in the US right now. You know, a lot of the debate is that, well, access to health care is an individual responsibility. And whether you do it through your personal insurance or your personal money or whatever, it's an individual responsibility. And in Canada, we've taken the society approach where access, we try to base it on the need as opposed to the financial resources of the person. So the US is spending all this much more money, and we have a significant number of people in the US that are getting world-class health care. And the average life expectancy of a Canadian is 3 years more than the average life expectancy of an American. And so it really does get into this value discussion of what is the value? Are we valuing the health status of our society, or is the value maximizing whatever each individual can access or afford? And again, that's the struggle with that question.
As well, I like to, and some of the other panelists have said the same thing, is not compare ourselves always to Canada. I started out by saying, you know, the three things, the beer, the hockey, and the un-American universal healthcare system. So, and we fall into a rhetoric when we're constantly comparing ourselves to the US, because we're not the US. And we need to look further abroad, and we tend not to do that. We become fairly insular, and we're just always worried about this slippery slope into US healthcare. So we need to look around the world where things are actually working and draw on some of those things that might be working better than they are here today. When I grew up as a little girl, you know, identity tied to universal healthcare system, I was always told we had the best healthcare system in the world. And I'll tell you, I was shocked when my dad developed cancer, why I ended up leaving Bay Street, coming to healthcare, and seeing healthcare up front and personal, and realizing that sadly, it wasn't as incredible as I thought. There were lots of incredible moments, but it wasn't, you know, some of the luster had come off of the healthcare system. And I think we just have an opportunity to put that back, but we need to draw on experiences. And why I came to healthcare was to bring, you know, try to bring business thinking to healthcare, which is happening much more, and to really focus on consumer, or the patient, if you will, at the center of care. And that's happening a lot more. But business thinking, and applying technologies and having entrepreneurs adding into the discussion of healthcare shouldn't be confused with private medicine, with private healthcare. It really is about how to improve that value, improve the outcomes for the dollars spent.
Very timely links into, I think, what's a fantastic question from the floor. So Sarah, who's with Innovative Medicines Canada, has asked, Dianne, see, if you're going to be up here, you're going to get questions. So how do we push innovative medicines in the hospital and in the doctor's surgeries? What's the solution? If we've got some great innovative things, how do we push them into the system? Sarah asks. I'd ask, should we push them into the system? But
how do we push, sorry?
Innovative, if we've got innovative medicines,
innovation?
How do we get it into the hospital and the doctor's surgery?
That is the challenge, right? And I can tell you, having spent some time looking around the world at innovations, that we have some of the best innovations, the best innovators, the best technologies right here in our country. And that's the thing that I get the most frustrated about, is that we're not adopting that innovation in many cases. We're forcing these entrepreneurs with their innovative ideas that could have significant impact here in Canada to go and sell abroad before they even get any traction here. Part of it, there's many issues, right, in healthcare. So one of the things that at CCI we're focused on is really just bringing the voice of some of these really brilliant entrepreneurs to the table with policymakers. I don't design policy, that's not my role, that's not what we do at CCI, but really being at the table so that any policy decisions that are being made are thinking about the impact and implication that it has. And then we're looking at strategic procurement and how we can start to get those into the system. One of the single biggest issues that I've certainly faced building healthcare companies in Canada is the inherent risk aversion that we have in healthcare. And so we need, it's a cultural transformation actually to reduce some of that risk aversion. And so it's profound. It has to start with government and into the institutions and penetrate that and give people an opportunity to realize that adopting innovation isn't, a huge risk. In fact, in my view, the risk is not adopting innovation.
Tom, would you like to make any comment on this issue of pushing innovation into the system and how it works for value?
Yeah, that really does strike a chord with some of the personal frustration that I feel with the healthcare system sometimes, in that Canada as a whole, we have a conservative approach to things. We are a cautious nation at times. And we really tend to enjoy a government scandal. When government spends money on something and it doesn't work, and then it becomes a scandal. And depending how much money government has spent on something and it doesn't work, then the demands start for the minister to resign, right? The minister has to be accountable, the minister needs to resign. And how stupid can that bureaucracy be? It's time to get new bureaucrats in there. And a couple of years ago, I had the opportunity to go to Estonia, which has probably the best or one of the best e-health record systems in the world. And they built it over a period of about 15 years or so, and they only had one contract to a non-Estonian IT firm. Everything else was developed by Estonian companies. And I asked them, I said, well, what happens when something doesn't work? Because if you're trying to build your own entrepreneurs, and some of them haven't done it before, and some of them are small companies, you probably had failures, didn't you? You gave money to companies and it didn't work. And they said, yes, you're right. We did. We had failures. We lost money. But the people of Estonia understand that you have to take on some risk if you're going to build the industry. And I think that's the piece that's missing here, because to take on a new piece of technology and to assume that risk and it doesn't work, if I'm the one that has made the recommendation, I've made a recommendation to my minister that could end the career of my minister. And so that's why you see that reluctance. And somehow as a country, we have to accept that if we really want to advance in innovation, you have to accept the risk of that as well.
Anyone else want to comment on that?
Well, I just don't like being pushed. You know, like if something's being pushed on us as a provider in that doctor-patient relationship for the value, I want to be involved in the process from the get-go as opposed to having something implemented or there it is, use it. I want to know how I'm going to use it, how it's going to benefit the patient, and that it has a tangible patient-oriented outcome that will benefit that patient. So I don't want to have it pushed on me. I want to be part of the conversation very early in the conversation.
Bettina, do you want to just add a quick note on Ken's comment?
As a patient, I'd be very interested in accessing something, even if it was risky, because your appetite for risk depends very much on your situation. And if your life is at stake, you will accept a different level of risk than when it isn't. So I believe we should not prohibit risk takers from taking the risk. Of course, we have to protect them and we have to learn from the experience, but I think I'd take a different stance on that.
No, but it's interesting when they survey patients and physicians, and they'll ask the patients, you know, what do you think is reasonable? If oh, well, there's a 95% chance you're fine, but a 5% chance you might die from this. They're like, okay. And you ask the physician what their risk is. Oh, it's got to be less than 1%. It's got to be less than 1%. And then you ask the physician, how about if it was you? Oh yeah, 5%'s fine. Right? So there is that dissonance between doctor and patient. So as you know, of course, we take that oath of first do no harm. And so we're much more conservative with regards to bringing something, and we're worried about side effects, we're worried about adverse events, we're worried about, harming the patient when we're supposed to be providing benefit. And so I get that.
So I've got 3 questions which I'm going to try and run through reasonably quickly. One of them's kind of an attempt to synthesize 5 or 6 questions that have been brought up, which is about the inequality in provision of especially medicines, but not purely medicines, across all the provinces and territories. We acutely see it in the rare diseases sector, but also in a lot of the cancer drugs. Can any one of you see a way forward to remedying the inequality in access between our provinces? If we are truly one nation and we're truly operating a national Medicare, why is that? What are we going to do to get from where we are to equality of access across the provinces to these expensive drugs? What's the challenges? What's the solutions? Tom, you know the challenges so well. I'll let you have first crack. That was cruel, wasn't it? That was so cruel.
Okay. I think he should take that one.
Yeah.
We'll just sit back.
Sure. So I won't talk about the U.S. I will talk about Europe, and whether it be continental Europe or Great Britain, almost any of the countries that we compare ourselves to within OSED or whatever, they have national health care systems. And by national, it means the Ministry of Health is a national ministry. So in Great Britain, there is one Ministry of Health, and it is the Federal Ministry of Health. So it sets the standards for the entire country. In Canada, in 1867, the decision at that time, when we had very little publicly funded health care, but basically the decision was health care decisions would be provincial decisions. And so while we have the Canada Health Act that sets out some very high principles, how those principles are interpreted are basically left up to the provinces. And if the federal government doesn't have a huge objection to how a province has interpreted that, then the federal contribution flows to the province. So we do not have a national healthcare system in Canada. And so we're constantly comparing ourselves on international comparisons to systems that have a single national system. And in Canada, we have a collection of regional systems. And so that's where you start to run into some of the inequalities that are there, because in one province, maybe the need that the population is turned on to is this new thing over here, and in another province, the population may be lobbying for something else entirely, and over time, it builds in different ways. And so it's always a little frustrating to hear about a national system when we are a collection of regional systems.
So the second of the questions, and I think this really does get to the nub of a very important question, and this is from the apocryphal Adam Smith, I believe. What does innovation in healthcare mean to you? What do you think it means to patients? What do you think it means to providers, and what does it mean to the system? Is it the same, or is it different, and do we know how it differs? So what's innovation? Bettina, you have a strong view on these things, I know.
Well, unfortunately, I have to admit that I rather define innovation by what it isn't. So I've been on record for saying that a product sitting on a shelf that is not accessible to the patient is not healthcare innovation, it's an invention. So innovation for me is something, healthcare innovation for me is something that delivers positive outcomes in our populations. And if we want to say with the type of society we want to be living in, for us it would be for everyone, not just for a subset. So I think that would be my headline on innovation. Next take.
Are we going down the line? Oh, as a provider, okay. So, I agree with what you're saying, actually, that, for me, innovation means doing something today that I didn't do yesterday that's different and that has value to the patient. So it doesn't have to have value to me, but my value would be secondary. In other words, I would have secondary gain. If my patient's doing well, I feel good about what I'm doing. So it all revolves around the patient. And so the innovation I would do is if I use this new drug or this new device or have this new treatment protocol, if that provided an important thing to them and it wasn't what I was doing yesterday, oh, I'm being innovative, right? And I would point it out to them too, because you want them to appreciate that something's, that we've got this whole idea of, personalized medicine. It's always been personalized, right? Like we're always making decisions about that person. And so, if I'm doing something different based on new information, I think that's innovative. And I talk to the patient out loud while I'm doing it so they see the value in it. And I can get back from them, are they interpreting that as value? Because if they are, then it's a win-win.
Well, actually, can I just quickly? Sure, I can.
No, you can't.
I actually would argue that even if we were able to deliver the same outcome, but for example, on much lower resources than we used to, that for me would also be innovation, because that would free space to do something else. So I would not, it doesn't have to just get better. I think it is not just better for the patient, but also for society. So I would take both sides of that.
But I think if you're taking care of the pennies, you're taking care of or the dollars or whatever, right? So if you're taking care of the individual patient, hopefully society is different, and every patient will have a different value. So I can't assume that what that patient values, and I go into this room and that patient will value the exact same thing. But I agree that it doesn't always have to be the addition of a new drug or the addition of a new device. It actually can be de-prescribing and saying, well, we've got new information that actually, this doesn't help you. This doesn't provide benefit. And so we can take those resources and send it down to the guy at the end, and he can reallocate it to vaccination programs. Right? And then you can reallocate your scarce resources appropriately.
That's really interesting. Most of my career, I've struggled with getting the idea of opportunity cost over to patient advocates and frontline clinicians. You two have clearly nailed it, which is excellent. Innovation for industry.
Innovation. So I think some of the language, the different stakeholders. So it's a good question because different stakeholders have different opinion, just the same as value. And that's part of the problem, why I think we end up being divisive and continue to be in silos and not change the status quo because we don't have common understanding of some of these ideas. And innovation, say, from my perspective as an entrepreneur, innovation isn't necessarily invention. Invention is something else. Innovation is the ability to commercialize some of these inventions. And I say commercialize because we need to be able to sustain what we do. So there needs to be a transfer of money. Canadians tend to think that healthcare is free and magically it just gets given to them. What they don't realize is that where we're managing the dollars, the scarcer dollars that we have on a growing population with growing demands, because we are artificially controlling access to care in many cases. And so Canadians are not getting everything that they should get and everything that they can expect. So you need to have that commercialization and change of dollars. And back to getting access, adopting some of these innovations, and it's about improving outcomes for patients, making sure that every patient in Canada can get the very best care in Canada, regardless of which province that they're in, and it not be an impediment because we're in Canada versus somewhere else. But it also is system innovation. How can we use some of these incredible new technologies to reduce some of the cost of delivery of that care and improvement of those outcomes? So it is not just saving lives and improving outcomes. But it is actually through improving the system and improving the efficiency, and so that the dollars go further and we can do better with them.
Tom, do you want to add anything on that? Or
Did you want to?
Ken can go. Go, Ken.
It made me think of something there, what you were saying. And, I'm focused in on that doctor-patient relationship in the office and stuff like that. But this will go maybe to some of the stuff you're considering, because I think innovation would be that we can't always think about healthcare, the bottom of the cliff mentality. I'm an emergency physician working in a small town, and I run around and people fall off the cliff and I catch them and we put them back together and then we put them back, right? And wouldn't it be better if we could just say, step away from the cliff, right? Take a step back. And so the social determinants of health is what I'm getting at. And so maybe these healthcare dollars, we get value if you put it into food security and adequate nutrition or a basic minimum income or something like that. And I know that takes away from what I'm happening on a daily basis on a one-to-one aspect, but I think that we've got to think more broadly and more innovative and then think of other social determinants of health and not just, here's this pill and call me in the morning kind of thing. Oh.
And back, I think, to what I was saying about the 19th, even the 19th century sort of worldview, right?
Yeah.
That didn't conceive of some of these things. And so it's shifting from that acute care
out to the
into prevention
community.
and wellness, into the community, into self-management of chronic disease. So there's so many other things that we can do. Technology can actually free up a lot of our providers so that they're able to focus on coaching and helping patients to help themselves. And I think that alone could have a significant impact on our healthcare system.
So, a question from someone who describes themselves as Peacock, friend of Chris, from Simon Fraser. So, Stuart, another question that I think gets to the nub of an issue here, and I'm going to start with Tom, if that's okay. There is a fundamental tension between what we value in healthcare when our loved ones are the patients versus when we place ourselves in the role of making decisions for populations. How can we move the debate on values forward given this tension?
I wish I had the answer to that. It's always theoretical until it's you or a loved one. And sometimes when you're trying to make those decisions, and I've said it with my staff, I've said it with ministers, as much as we want everything to be evidence-based, sometimes we're putting a price on hope. Yeah. If there's a certain treatment that's coming out and it's new and it might help, I don't know, some sort of cancer or something, but the evidence is saying successful in 30% of the people that take this treatment. Where's the cutoff? Is it 30%, 50%? Is it 10%? And you just can't close the door to hope all the time either. And so I've been in situations where we have agreed to fund things where we know the probability of this being successful is probably fairly low. But if we don't do this one, we are sending a message that government doesn't care. So it's even more than just you know, how do you make the decision for society versus when it's yourself? It's also, what is the role of maintaining hope within the system sometimes as well? And so trying to put price tags on all of that tends to get very, very difficult. It's
that social value of the social support, you know, that signaling that we are all in this together, and how much should we be willing to pay for that? You know, that's, I think, one of our big challenges. We've all seen the decisions that revolve in that space, and I'm always glad to be the analyst and not anywhere near the real decision. But I think that's very true. There's a value there that we need to learn how to recognize.
I think we've seen it in all the provinces. At one time or another, there is always the headline, you know, in a newspaper, the photo of a patient that has whatever sort of condition and requires, you know, there's an experimental drug available that costs several $100,000, and there is some sort of chance that this may cure the condition that the individual has. And then the headline is always, you know, if government doesn't do this, I will die. And that is a true statement. If government doesn't step forward, that individual probably will die. And it's balancing those sorts of challenges.
Bettina.
Well, I obviously have an opinion on that because I get this question all the time. So I believe if a system and a concept we're having is right, then also the application on the very bottom has to be right. So it's nice to have abstract good ideas and good intentions, but in the end, it's what happens at the ground. If what happens at the ground is not what we thought would happen, then either our concept was wrong or the application didn't work. So we have a bug somewhere in the system. And as advocates, we are there. I see us as sentinels pointing out these situations that we find unacceptable to us. I think it's also that an undiagnosed person cannot fathom what it is to be like. And I'm a medic, and I thought I had an idea what death looked like. The first patient I ever saw in hospital was someone with pancreatic tumor, and he died in the time while I was there. So I thought I had seen death close up. I can tell you, if it hits your own husband, it looks totally different. So I think it is about working backwards. Start with a situation that we ideally would like to see on the ground, and then engineering backwards what a system would have to look like. And now everyone will go, yeah, every patient will want a Ferrari. And that's actually not what I see. People have actually quite modest, well, not modest, but they will tell you something like, I want to live. Actually, what people say is, I want to see my children grow up. Is that immodest? Is that asking too much? So I have an issue with someone then goes, yeah, your children, that's fine if they grow up with their father. I mean, have the discussion with my girls. You're very welcome. So I don't think we should argue that way. So it's about thinking, what would we like to see? Another aspect is dignity. People want to be treated with dignity. Is that asking too much? I mean, I always wanted to become a surgeon because I like the work and I like the results of the work. You know, you put these, I don't know what you call them in English, but you put these patients in these ridiculous gowns that are, you know, open at the back. In German, we call them something like wing shirts, like, you know, angel wings, like that. I had never had an operation. It was the first time this year in January. And I can tell you, your ability to have a decent discussion when you have your backside open is kind of impaired. So it is simple things like that. I mean, we're not going to now have a discussion about the price of a gown, have we? So a lot of these things don't come with big money tags, but it's our attitude of the system that I think just a small change there would go a long way. So I think I was like, we have to rework the system, how we want to see it operated. At the time when we are the patient in that situation, we get the care that we hoped and thought we would be getting. I really like what you said about your father. I also grew up living, well, I grew up in a different country. I also believed it was the best healthcare system ever, of course. So until it hits you personally and you realize that's not true. So, but I think we shouldn't give up that aspiration to live in the best healthcare system possible.
Thank you very much. Okay, someone's been doing a seance because Kenneth Arrow has given us a question, who's, for those who don't know, is the founding father of the discipline of health economics. will we ever be able to carve out proactive funding for the social determinants of health, preventive care, as long as we're willing to pay for hope's sake? Anyone want to comment? This is the nub of where we live, isn't it? If we want to have proactive funding of the determinants of health and make those better, how do we do that and do hope?
If you read the book about the social determinants, right, lots of these things are something that shouldn't be coming from healthcare budget. I mean, there's education in there. Should we finance education from our healthcare budgets now? I think social determinants are way larger than just health-related. So I think that's a cheeky question.
But it's
every dollar in the healthcare budget could be in the defense budget, the science budget, the education budget, the social welfare budget. There's always that move between. So, yes, there is an opportunity cost in the other spaces, but how do we as a society have that conversation?
But the question is a logical fallacy because it proposes a false dichotomy that you can't have both, right? That they're mutually exclusive and that you have to pick one or the other, and it puts it at odds with each other. And I wouldn't say that's not necessarily the case. 2 points. One is the research out of the United States where they have all these state-based systems. The data out of there says the states that put more dollars into social determinants of health have lower healthcare costs and better outcomes. Okay? And the second point is how we treat our most disadvantaged or our sickest is a reflection on us as society, and so we have to collectively say, these are the values we have, these are the people in need, and this is what we as society are willing to support them at. And that's, what gets people elected or thrown out.
Any comment, Tom? Anyone else want to comment on this? False or not?
Yeah, it is a very valid question because, I mean, depending on which model you use for the social determinants of health, what we spend within the traditional healthcare budget is 10 to 20% of the total determinants of health. But yet governments in Canada are spending 40 to 50% of their budget on that 10%. And this plays out across the country every year when governments are starting to put together their budgets. They'll say for inflation and new programs, we have X millions of dollars available, and how are we going to allocate this across all of the government departments, education, health, highways, all of that. And every year in every province, the health ministry will come in with a list of things that they think they need to do that is bigger than the dollar amount the government has for everybody. The expectations for new services far outstrip the resources that government has. And I feel that acutely because I know it's absolutely foolish for healthcare to get every new dollar because you would actually make society the poorer for it. But it's how do you make that decision in the totality? I mean, having literate 7- and 8-year-olds is one of the best things you can ever do to increase health status for when they're 65 or 70. And maybe that's where the money should be going.
Dianne.
Well, I would say, it's projected that by 2030, healthcare spending will consume almost 80% of provincial budgets. And so that's totally unsustainable. And that means that there isn't money for infrastructure and roads, and maybe we do away with some of the education, and we'd have to make some tough choices. So I think we have a moment in time now that we need to really consider adoption of some of these technological innovations that particularly our Canadian entrepreneurs are bringing to the table, because they're made in Canada. It's going to help the economy as well as make improvements to patient outcomes and reduce some of the costs. So when Tom, you were talking about providing hope. I mean, I built a cosmetic company. That's how we sold hope for people. So hope is important. However, we don't have to just hope that medication is going to work for that particular patient. If it's $1 million one, we're going to do a test. I mean, today, You know, we have pharmacogenetics. We have, so this is a pitch for the panel that we have on later on AI. And so I hope that you'll attend. But we have people there who are analyzing, the sequencing of DNA to determine, who might get a disease, or anyway, there's so much happening that could help the system so that we could reduce some of the costs. I mean, these aren't necessarily, the prices are coming down on a lot of these things, so there are solutions, right, that can help us. But we have to do something about, what would happen by 2030 when we have 80% of our budgets gobbled up.
Excellent. So following on nicely from that, can anyone talk about models of innovation adoption in other countries that seem to work, that we could learn from? Enough of, we know how bad this problem is. Anyone got any outlines of a solution that seemed to be worked elsewhere?
You're the one that's lived in like multiple countries, so I think you should take
that
that question.
Wasn't it?
If it's Germany, Sweden, Britain, come on.
Actually, I've been reading up on that topic because I've been, it's like, I think as a patient advocate, you should be advocating for constructive solutions, not just complain about what's not working. There's a very interesting author, I think, in my mind, she's called Mariana Mazzucato, who has written a book, it's called The Entrepreneurial State. And she argues that the state finances large parts of the risky parts of innovation and should therefore retain a return on investment in those parts. And she, I'm German, I wasn't aware of it, quoted a German system where there is it's a fund that is supporting innovative startups, promising startups, so it's a selective process, and if these people are promising, they offer them, I think it's €500,000. If the startup doesn't work out, the people don't have to pay anything back. However, if the startup is successful, the state retains, I think it's 12% of the shares, and that then gets used to refinance the system. So I think we have to get a bit smarter about looking into these financing schemes, and it's a bit, of course, we start from a direct patient experience, and you end up in financing innovation, who would have thought? But I think we have to get better at a society thinking, where do we want to put our money, and how do we retain some of what we have generated? Because we have seen, like in Europe, we've seen Ireland is a good case, where the state has been quite successful in attracting innovative companies, but they have not been able to distribute that evenly. And we have now the situation where there are pharmaceuticals produced in the country, but the patients in the same country do not have access to the very pharmaceuticals produced there. And I think then you go, which part of industrial policy didn't work out? So I think it's like there are ways to start looking for it. And I don't know, it's not even my background, that's your job, actually. So
no, my job is to lean forward and look interested. I think I'm doing it quite well. On this occasion, I am interested, but the rest of the time it's just my job.
So I'm going to tie together, Sweden with ex-BlackBerry here.
Okay.
Ready to watch it happen?
Okay,
here we go.
Like a magic trick.
So there was a study put out last year from Sweden. When you're looking at innovative ways for technology to have an impact and be innovative and find value, is, I'm an emergency physician. Number one reason people die is usually sudden cardiac arrest, right? It's cardiovascular death. And so what they did in Sweden was they trained a whole bunch of people on CPR. Okay, that's good, like high quality CPR. But then they got them to get their cell phones, and the dispatcher, whoever called in 911 in this out-of-hospital cardiac arrest, would be able to locate everybody else with their smartphone within 500 meters of the person who dropped, who knew how to do cardiac arrest. And they crowdsourced it to get those people to the person in a timely fashion. And they showed that, of course, CPR rates went up tremendously. And so should we be training? I mean, who here is, under the age of 20 and they're sitting there like this all the time? Should we be training all of our young people in school, because we talked about education, on how to do CPR, but through their smartphone, so that they get prompts on how to do it and can be first responders? Because everybody's got one of these. Everybody's out there, and everybody could play a role in making sure our healthcare system is better. Doing that They took it one step further and said, well, CPR is good, so, you know, harder, faster, stronger, right? CPR is good, but the next step is defibrillation. And so what they did was, in Sweden, they did a mathematical model of all the out-of-hospital cardiac arrests and said, where should we put drones with defibrillators on them? And how quickly will they get there compared to the first responder paramedics? And they found, of course, there would be a significant time reduction with regards to the time the defibrillator would get there. So soon you can see like this, we'll all be wearing some Fitbit if you win the prize, right? If you win the prize today. You'll be wearing some Fitbit and it'll be like, you'll drop, and all of a sudden this Amazon drone will come out of nowhere, evaluate you, and go, clear, you know, and you'll go like this, and then you'll come as a first responder. And we'll have a healthy society.
So it was less an answer and more a piece of performance art, but it was fantastic. It was absolutely fantastic.
It's always about edutainment, right? Well, edutainment. If you try,
I don't know what you were talking about, but I love watching you talk about it. It was the best.
So Amazon is this big company, and no, never mind.
No, it doesn't compute. So we've already had a fantastic time. I've learned so much. Coming to the last question, and here's a favorite one. So how do we balance spending between administration, red tape, and actual patient care? Anyone want to comment on that point? How do we get a hold of our apparently out of control administrative costs in healthcare? There's a deathly hush.
Adopt technology.
Yeah.
So I'm chief of staff at my hospital, so I wear that administrative hat as well as a frontline clinician. And so I think I would just tweak yours, adopt technology wisely.
Mm-hmm.
All right. Just adopt it.
Adopt it.
We can choose technology wisely, the way we can choose anything else wisely.
Choose wisely. There you
go.
Said that.
So anyway, final words from each of you. Start with Tom.
Final words. I think, as has been mentioned here this morning, the next 20 years, Canada, the whole Western world, is really facing a challenge with the financing of the healthcare system. That's not a surprise to anyone that's been involved in the system. And I think today, all of the answers are not self-apparent. We don't know how we're going to deal with all of that. But you can be, glass half empty, glass half full. You can just bemoan the fact the train's going to crash and we're all going to die in the crash. Or you can say collectively, we can probably find our way out of it. And so, when you hear conversations about what innovation can do, about how as a society we need to be able to start to talk about these things, it does give hope for the future. And without getting political, I hope, but when you look at what's gone on in Canada in the last 18 months with the national conversation about medical aid and dying, where, again, very strong opinions on both sides of that conversation, but it wasn't nearly as divisive nationally as a lot of us thought it was going to be when it started. Canadians had a mature conversation about how to handle it, and while implementing MAID, there was also a lot of talk about what is palliative care and what does it mean. And oh, by the way, palliative care isn't the last month of life. Palliative care could be 4, 5, 6 years, depending on the person. The conversation was elevated. And we didn't expect that going in, or at least I didn't. And so that gives me hope that as we wrestle with these, that Canadian society perhaps is ready for that.
Well, I started out by saying that we define ourselves by 3 things, if anyone remembers what those are. But one, the beer. Yeah, I saw you at that last night.
Just because this is being recorded, I had wine.
Oh, yeah, that's right. So I'm confident that our taste in beer will endure, that our hockey prowess will continue to be legendary. And I do believe that if we bring health tech entrepreneurs to the table with policymakers to have these conversations, to include them and consider ways of adopting innovation into our healthcare system, that once again, the Canadian healthcare system will be that shining national treasure and will be in place for not only for us, but in the future for our children and our grandchildren.
Ken, final word. Okay, final words. All right, 3 things. First thing is, I want you to remember what you do matters. So whether you're a provider, whether you're an innovator, whether you're some kind of regulator, whether you're in government, what you do matters to the healthcare system. So please don't stop doing it, because it's important. And that's the first thing. The second thing is, when you're thinking about all of this and when you're doing all of these things, you've got to remember there's a patient at the end of it that really has hope. And my belief is we still have the best healthcare system in the world. It may have flaws, it may have blemishes, but I wouldn't practice medicine anywhere else. And the third thing is, be skeptical of anything I say.
We end with the patients, Bettina, as we start.
Well, I'm obviously not a patient, but I was a carer. I actually think that despite the challenges we are facing and despite the many reasons to be truly upset, I believe that this is a point in time where the realization has occurred that we cannot continue like this, and there is a willingness to really work at it and look hard. So I haven't been in this space for that long. So my husband died now 5 years ago, and I've been in advocacy for about 3 years. At the beginning, the silos there were true silos, and people were fighting and accusing each other. And this has, in this very short time frame, this has changed. So that there is an understanding that we have to work together, whether we like it or not. That the solution is probably going to be somewhere in the middle and feel a bit of a lame compromise for everyone, but that there are also opportunities via technology, social media, that make things possible that we maybe have never dreamt of. So it's, in a way, it's the worst and the best of all times to live.
Thank you very much. Ladies and gentlemen, thank you for the excellent questions from the floor. It made my job really easy. I hope you'll now join me in thanking our fantastic panelists for a really interesting discussion.